Imagine trying to surgically repair a wet sheet of single-ply tissue paper.
Oh, that sounds impossible.
Right. But you have to use a needle made of solid steel.
Hmm.
I mean, if you push too hard, the paper just shreds immediately.
Yeah, it would just disintegrate.
Exactly. And if you try to be, incredibly gentle, the mere physical tension of the water molecules might still cause it to tear apart at the slightest touch.
It's a completely unforgiving environment.
It really is. And when you look at how we traditionally think about healing the human body, there's this ingrained expectation of, well, extreme gentleness. We think of soothing ointments or like soft protective bandages.
Keeping a vulnerable area perfectly safe from any further harm, right? First, do no harm.
First, do no harm, exactly. You generally want to isolate and protect damaged tissue.
Yeah.
But when you step into the world of modern regenerative medicine, specifically when doctors are trying to heal the body's most vulnerable paper-thin tissues, that logic gets flipped completely upside down.
It really does. It becomes highly paradoxical.
Yeah. We're looking at a therapeutic landscape where the very act of delivering the cure inherently and unavoidably causes micro-trauma. So welcome to the Deep Dive.
Glad to be here.
Today, our mission is to unpack a very specific, highly debated risk for you. It shows up in both aesthetic and regenerative medicine. We are looking at the localized micro-haematomas and purpura that can form when you inject vascularly fragile atrophic mucosa with a regenerative compound called polynucleotides.
And, this is far from just a theoretical risk debated in medical journals.
Right.
If you're a practitioner dealing with tissue that has lost its fundamental structural integrity, this is just a daily clinical reality. You're constantly balancing the introduction of, well, a temporary mechanical injury in order to initiate a long-term cascade of profound biological healing.
It's fascinating. And to get to the bottom of this paradox for you today, we were synthesizing some truly wild insights from a really eclectic stack of sources.
A very weird mix, honestly.
Yeah, totally. Rather than just reading through papers, we're going to look at the underlying biology connecting aesthetic dermatology protocols for under-eye treatments, gynecological clinical pilot studies on vulvovaginal atrophy.
Which is such a massive topic on its own.
Right. Plus, we've got systemic reviews of severe adverse events from traditional facial fillers. And get this, we even have a highly specific gastrointestinal pathology case study.
I know, it sounds like a bizarre mix of specialties, but it really ties everything together perfectly.
It's going to blow your mind when we get to the architecture of your blood vessels.
Because, frankly, biology doesn't care about medical departments. The physics of a needle interacting with a fragile blood vessel is exactly the same, whether you're working on a patient's face or, treating intimate health conditions.
Well, okay, let's unpack this. Because before we can even touch on the risks of injecting this tissue, we really need to paint a clear picture of the canvas we're working on, right? We need to understand why this specific tissue is so incredibly vulnerable in the first place.
Yeah, and to grasp that vulnerability, you really have to look closely at the architecture of what we call atrophic mucosa.
Okay.
So in the context of the gynecological studies you mentioned, the ones on vulvovaginal atrophy or VVA, we're looking at a core component of the broader genitourinary syndrome of menopause, or GSM.
Right, GSM.
And the main driver here is this massive physiological shift in hormones. During peri- and postmenopause, a woman's estradiol levels just plummet drastically.
And we're talking about dropping from premenopausal peaks, around 800 picograms per milliliter, down to below 30.
It's a huge drop.
That isn't just a minor fluctuation, right? That is a systemic withdrawal of the tissue's primary fuel source.
Exactly. And the physical consequences of that withdrawal are immediate and severe. The estrogen basically just stops feeding the tissue.
Wow.
If you were to look at the vaginal epithelium under a microscope during this stage, you'd see it thinning out dramatically. It entirely loses its keratinized features.
Yes, let's break that down for a second, because keratinized kind of sounds like, I don't know, car wax.
Yeah, I guess it does.
Keratin is essentially this tough, waterproofing protein that acts like a cellular suit of armor, right? It's what makes your outer skin resilient to friction.
Right.
So when the mucosa loses that armor, it becomes completely defenseless.
Defenseless, exactly. The architecture literally flattens out. You have these natural sort of accordion-like folds of the tissue. They're called vaginal rugae, and they just disappear entirely.
And flatten out.
Yeah, but the real crisis is actually happening just below that surface in a layer called the lamina propria.
Okay.
This connective tissue layer suffers this massive depletion of collagen and elastin fibers. So the tissue loses its stretch, it loses its moisture retaining capacity, and its overall physical thickness.
Okay, so think of Healthy, estrogen-rich tissue, like a thick, robust sheet of bubble wrap,
Hmm.
right? And it's securely holding and protecting these delicate little glass tubes.
I like that analogy.
Thanks. And those glass tubes are your capillaries and veins.
Hmm.
The bubble wrap basically absorbs all the shock and keeps everything in place.
Right.
Now, atrophic mucosa is like taking away all that thick plastic bubble wrap and replacing it with that single wet sheet of tissue paper we talked about earlier.
Yeah, you've just stripped away all the protection.
Exactly. Those glass tubes, the blood vessels are now completely exposed. They're unmoored and completely unsupported.
And to understand exactly what happens when veins lose that surrounding armor, we actually have this fascinating contrast in that gastrointestinal pathology source we mentioned.
Oh, right, the GI study.
Yeah, so there's this rare condition called idiopathic myointimal hyperplasia of mesenteric veins, IMHMV for short.
IMHMV, got it.
It involves a patient presenting with severe lower abdominal pain, and the pathology reports reveal that the veins in their colon have become abnormally thickened.
It's crazy. There's this massive proliferation of smooth muscle directly in the walls of the veins themselves.
Yes.
They become super tough, hyper-thickened, and eventually they just get totally occluded. They're basically wearing heavy medieval armor from the inside out.
Exactly. And the point of bringing that up is, if a surgeon's instrument were to graze those IMHMV veins, they wouldn't just easily rupture. Their dense structure actually provides its own mechanical defense.
Well, can take a hit.
Right. Now, flip back to the atrophic mucosa you just described. It is the exact opposite end of the physical spectrum.
Right.
The surrounding connective tissue has just melted away, leaving the vessel walls dangerously thin, which leads directly into the clinical manifestation of what we call purpura.
And purpura being those purplish lesions caused by bleeding under the skin.
Exactly. The mechanism of purpura, specifically senile purpura, which happens as our skin ages and suffers chronic sun damage, is basically identical to the mechanics of vaginal atrophy.
Oh, wow. I didn't realize they were that similar.
Yeah, mechanically speaking. When the connective tissue in the dermis or mucosa atrophies, the blood vessels literally lose their physical scaffolding. So when any shearing force enters the area, those vessels easily tear apart because there is just no collagen matrix holding them secure against the pressure.
So literally, if you just rub the skin too hard, or if needle slides past, the vessel can't, bend or flex out of the way. It just snaps.
It just snaps.
And the resulting bleeds come in different classifications based on the size of the hemorrhage, right? Like a petechia is a tiny pinpoint bleed, less than 2 millimeters across.
Correct.
But an ecchymosis, what you and I would just call a standard bruise, is a larger pool of blood over 10 millimeters across.
Right. So taking a step back, you have these blood vessels floating unmoored in a very thin, very fragile space. Introducing any foreign object into this microenvironment, no matter how small or how perfectly maneuvered, carries a profound mechanical risk.
Which brings us perfectly to the payload. Because if the tissue is this delicate, if it's practically disintegrating upon contact, what on earth are we trying to inject into it and why?
Well, the compound in question is a class of injectables called polynucleotides,
Okay.
often abbreviated in the literature as PNs or PN-HPT. The HPT stands for High Purification Technology.
And the origin story of these molecules is just wildly fascinating. When you read the source material, it explains that these are highly purified DNA fragments.
Specifically, polymers ranging from 50 to 2,000 base pairs.
Right. And they're extracted primarily from the gonads of salmon or trout.
I know, it sounds a bit like science fiction to be injecting fish DNA into human tissue.
It really is.
But the biological compatibility is actually astounding. Polynucleotides were initially researched and developed for severe wound healing, like treating chronic diabetic skin ulcers.
Wow.
And they operate entirely differently from traditional dermal fillers, which are generally made of heavily cross-linked hyaluronic acid, or HA.
Right. If you think about traditional HA fillers, their main job is to just occupy physical space.
Just adding volume, yeah.
Yeah, so if you want to compare traditional fillers to polynucleotides, think about a sagging mattress. Using an HA filler is like unzipping the mattress and stuffing it full of cotton just to puff it back up and make it look plush on the outside.
Great analogy.
But polynucleotides don't act as space occupiers. They are like hiring a factory of microscopic workers to actually go inside the mattress and forge entirely new metal springs.
Exactly. The medical classification for them is biostimulators. When these long DNA chains are injected into the tissue, they don't just sit there.
What do they do?
They're naturally and gradually broken down by the body's own enzymes, specifically nucleases. And as these enzymes cleave the salmon DNA, they passively release a localized pool of nitrogen bases, nucleosides, and nucleotide precursors directly into the tissue.
Oh, wow. So they're essentially handing the local dermal fibroblasts a massive pile of raw, highly specific metabolic fuel.
Exactly.
And those fibroblasts are the exact cellular workers responsible for building the bubble wrap we talked about.
Right. By flooding the local environment with these specific nucleotide precursors, the PNs stimulate the dormant fibroblasts to wake up.
Get back to work.
Exactly. They start aggressively synthesizing type I collagen, elastin fibers, an entirely new extracellular matrix. Plus, they alter the local osmotic pressure, drawing in massive amounts of hydration.
Which makes sense.
Yeah, that hydration is a fundamental prerequisite for those cells to even begin the construction process.
Okay, so you get this incredible regenerative cellular level repair. But to really understand why clinicians are so eager to use PNs for this delicate atrophic tissue, you have to look at the terrifying risks of what happens when you use traditional, heavier fillers.
It's a stark contrast.
It is. We looked at a massive systematic review of adverse events related to calcium hydroxylapatite, or CAH, and polycaprolactone, PCL.
And that review provides a very sobering reality check. It analyzed data from over 5,000 patients using CAH.
5,000, wow.
Yeah, and while the majority of side effects are mild and transient, there is a very real documented risk of severe delayed adverse events.
Like what?
We're talking about the formation of hard, calcified nodules, foreign body granulomas, where the patient's immune system aggressively attacks the filler, facial cellulitis,
Yikes.
and perhaps most frighteningly, severe vascular complications.
Right, the sources actually cite cases where impending tissue necrosis and even visual impairment or complete blindness occurred because the filler accidentally occluded a blood vessel around the eye.
It's terrifying.
And if we tie this back to that gastrointestinal case study, the mechanism makes total sense. Just like those IMHMV veins in the gut became dangerously thickened and occluded from the inside out, injecting a thick, viscous filler like Cayasha into a tiny facial vessel acts like a physical cork.
Exactly. It plugs it up.
It causes immediate ischemia, basically a complete blockage of oxygen to the surrounding tissue.
And polynucleotides, by contrast, have a much lower viscosity. They're essentially just a watery gel.
Okay, so they wouldn't plug anything.
No. And they don't possess direct pharmacological activity, meaning they don't force a localized immune panic, and they don't form those hard encapsulating foreign body granulomas. Because they're so fluid, they generally avoid those severe ischemic risks entirely.
Okay, here's where it gets really interesting.
Okay.
We have this superior safety profile. We have this incredible biological payload that can actually rebuild the lost collagen springs from the inside out.
Yeah.
But we still have to physically deliver this watery gel deep into that fragile, wet tissue paper mucosa.
Yes. The mechanical delivery method fundamentally collides with the tissue's physical fragility. This is the exact collision point where theory meets practice.
Let's walk through the mechanics of the actual injection process for a second.
Yeah.
The protocols described in our sources utilize techniques like nappage, right?
Yes, nappage.
This involves the practitioner making multiple, highly superficial micro-injections spaced just 0.5 to 1 centimeter apart across the entire affected treatment area.
Alternatively, they might use submucosal microdroplet techniques, delivering just tiny little beads of the gel. But in either case, they're using the absolute thinnest needles available in modern medicine, usually 30 to 32 gauge needles.
To visualize that for you, a 32 gauge needle is roughly the thickness of a couple of strands of human hair. It's incredibly small.
Very small.
But even with a needle that tiny, you are still performing dozens of physical punctures into a tissue matrix that has zero structural support. Which leads us to the core risk we're analyzing today, the localized hematoma.
Right. And a hematoma at its core is simply a localized collection of blood outside of the blood vessels pooling underneath the tissue.
Like a deep bruise.
Basically. When this occurs in the intimate mucosa or in the very thin, creepy skin under the eyes, it presents as this tender, swollen, purple or bluish bruising that can be quite alarming for the patient.
I bet. And the source material originating from the Women's Health Clinic makes a point of being incredibly firm about this reality.
They do not sugarcoat it.
Not at all. They explicitly emphasize that vascularly fragile atrophic tissue may bruise, bleed, or tear even with the most careful, low-volume work imaginable. You can have a practitioner with flawlessly perfect technique using the tiniest hair-thin needle, And the sheer lack of subepithelial cushioning means that the needle's edge is still going to nick those unmoored capillaries.
It is an unavoidable mechanical reality of operating within that specific anatomy. You just cannot bypass physics.
Okay, I have to push back here because this is where the logic feels completely counterintuitive.
That's your...
If the entire goal of using polynucleotides is to heal the tissue, to stop the micro tears and eliminate the fragility, isn't it entirely counterproductive to subject the patient to dozens of needle punctures, physical trauma, bleeding, and hematomas just to deliver the cure?
It sounds backwards.
Right. Aren't we intentionally making the problem much worse before we make it better?
That is the exact paradox we noted at the beginning, and it's a totally logical concern for anyone looking at this procedure. But to understand why it works, you have to ruthlessly separate the mechanical delivery from the biological payload.
Okay, walk me through how those two things are separate in the body's eyes.
The microtrauma, the needle physically puncturing the epithelial layer, the resulting transient microwheels, the pinpoint petechia, those are purely mechanical side effects.
Because of the needle.
Exactly. It is simply the physics of a sharp object moving through an uncushioned space. It is absolutely not an immunological rejection of the polynucleotide gel itself. The trauma is instant and physical. The healing payload is chemical, cellular, and long-term.
So the bruising doesn't mean your body's rejecting the treatment or that the procedure is failing.
Far from it. The body isn't fighting the salmon DNA fragments. In fact, that initial mechanical microtrauma from the needle actually serves a secondary purpose.
Oh, really?
Yeah, it initiates a mild, highly localized, acute inflammatory response. And that response automatically triggers the body's natural wound healing cascade.
Okay, that makes sense.
So when you combine that mobilized natural defense mechanism with the sudden, massive influx of DNA building blocks provided by the PNs, you generate a highly synergistic regenerative effect.
That makes biological sense, definitely. But from a clinical safety perspective, practitioners still have to be incredibly vigilant, right? Because unexpected bleeding in postmenopausal women can be a massive red flag for conditions far more serious than just vaginal atrophy.
That is a critical distinction to make. The Women's Health Clinic source explicitly mandates that clinicians must be highly skilled at distinguishing between a benign, entirely expected post-injection petechia and a serious underlying pathology.
Right.
If a patient presents with unexplained postmenopausal bleeding, active viral infections, or suspicious undiagnosed ulcers, you do not inject them.
Full stop.
Full stop. You absolutely must rule out severe issues like endometrial cancer or active herpes simplex before you ever consider picking up a needle.
So the risk of a hematoma is exceptionally high, but it's considered an acceptable temporary mechanical byproduct of a biologically necessary delivery system, provided the patient is rigorously screened beforehand.
Exactly. Which brings us to how this clinical reality is actually managed day to day and why it is so vital for you as the patient or learner to understand what is actually happening under the skin.
Right, because this risk isn't uniformly identical for everyone who walks into a clinic. Some people are going to bruise just looking at a needle, and others might barely show a mark.
True. The probability of a hematoma forming depends heavily on the individual's unique baseline state.
Like what?
Well, are they currently taking blood-thinning medications? What is the exact density and severity of their specific atrophic tissue? What is the unique underlying anatomical pattern of their vascular network?
Right, everyone's veins are mapped out a little differently.
Exactly. All of these fluctuating variables mean that the exact risk profile is highly individualized.
Now, if the needle is the primary culprit causing all this mechanical trauma and bruising, you might be wondering why doctors don't just skip the needle entirely.
And they can.
Yeah, the sources actually show there are alternatives available. We looked at a real-world study involving 54 postmenopausal women who used PN-based vaginal ovules and topical creams. 0 needles required.
And the data from that topical study showed fantastic, measurable results. By applying the polynucleotides topically over a set period, patients saw highly significant improvements in their vaginal health index, or VHI scores.
For those unfamiliar, let's break down that index real quick. It's a clinical tool that measures 5 specific metrics: vaginal elasticity, volume of fluid secretions, intravaginal pH levels, overall mucosal integrity, and baseline moisture.
And the study demonstrated that vaginal hydration improved by almost 60%.
That's massive.
It is. And superficial petechia, those tiny spontaneous bleeds that happen just from daily life, improved by over 51%. And they achieved all of this without a single needle puncture.
So wait, If the topical cream is that effective at stopping the spontaneous bleeding and restoring hydration, why are clinicians still pushing for the more traumatic submucosal microdroplet injections?
It really comes down to the required depth of the tissue remodeling. Topical applications are incredible for surface hydration and restoring the superficial mucosal barrier.
Right.
But when you're dealing with severe atrophy, where that deeper collagen matrix of the lamina propria has completely degraded, topical creams struggle to penetrate deeply enough to reach the cellular workers.
So if we go back to our earlier analogy, the topical cream is great at fixing the fabric on the top of the mattress, but it can't reach the broken springs inside.
Exactly.
The needle acts as an elevator, bypassing the surface and taking the DNA building blocks straight down to the basement where the fibroblasts the construction workers actually live and operate.
Spot on. The injection forcefully delivers the biostimulator directly into the compromised extracellular matrix.
Okay.
For context, the extracellular matrix is essentially the biological scaffolding and mortar that sits between the cellular bricks. You have to get the material into that mortar to rebuild the structure. But, as the sources repeatedly and carefully warn, clinics must treat polynucleotides as an emerging regenerative treatment.
Right. It sounds magic.
No, it's not. The biological mechanism is incredibly sound, and the early pilot data is remarkably strong, but it is not yet a globally proven, universally guaranteed cure for the entirety of genitourinary syndrome of menopause.
And when you think about what this means for you and your own understanding of medicine or choices you might make for your own care, it really comes down to a delicate balance.
It really does.
You have to weigh the exciting cellular-level biological potential of these DNA-based biostimulators against the simple, unavoidable physical realities of needle trauma. And this applies whether you're looking into intimate health treatments or something totally different like regenerative under-eye procedures.
And the under-eye connection is a brilliant way to conceptualize this. The periorbital area, the skin around your eyes, is remarkably similar to the vaginal mucosa in terms of its profound structural vulnerability.
Yeah, the aesthetic protocol source specifically notes that the periorbital area is one of the most delicate, highly vascularized zones in the entire human body.
It's incredibly thin.
It is. It's incredibly prone to developing a thin, creepy texture as we age, and it's highly sensitive to fluid retention and swelling.
So injecting PNs under the eyes carries the exact same mechanical risks: swelling, bruising, and transient asymmetry.
Because, just like the atrophic mucosa, the skin there is incredibly thin, and the dense network of blood vessels lacks any significant subdermal cushioning.
Exactly. In both scenarios, whether for aesthetics or intimate health, you are consciously choosing to endure a few days of potential swelling and localized micro-haematomas in exchange for the promise of long-term structural cellular repair. It is a highly calculated biological trade-off.
Let's bring all these threads together. We started our journey by looking at how the systemic loss of estrogen, combined with the natural aging process, systematically strips away the protective collagen and elastin from our most delicate tissues.
And we examined how the loss of that structural bubble wrap leaves the capillaries and veins completely unmoored, perfectly mirroring the fragility and tearing mechanisms we see in senile purpura.
We discovered that while polynucleotides offer an incredibly safe, non-viscous, DNA-based method to stimulate your own fibroblasts into rebuilding that tissue from the ground up,
The raw physical act of delivering those molecules via a 30-gauge needle into an unsupported vascular network carries an inherent, almost unavoidable mechanical risk of causing microhematomas and bruising.
But before we wrap up today, this deep dive raises one final, truly fascinating biological paradox that isn't explicitly resolved in the clinical literature, and it's something we want you to think about.
I love this part.
We know that tissue bruises primarily because it lacks a supportive collagen matrix. And we know that over a period of months, polynucleotides genuinely rebuild that matrix and restore structural support to those exact blood vessels.
So, if the tissue becomes physically and structurally stronger after the completion of the first treatment cycle, does that mean the inherent risk of microhematomas actually decreases with every subsequent treatment session you undergo?
As the biological payload successfully builds new layers of bubble wrap around your veins, does the tissue inherently become more resilient to the shearing force of the needle? Could the very first injection, ironically, be the only one that truly causes a severe bruise?
It is an incredible concept to leave on. The idea that the cure eventually builds a physical shield against the very mechanical trauma used to deliver it in the first place.
We will leave you to mull that one over. Thank you for joining us on this deep dive, and as always, keep questioning the fascinating and sometimes wildly paradoxical mechanics behind modern medicine.